So damned if you do, damned if you don't. How to decide when you have two non-ideal options. So 80-year-old female with 5 left-sided rib fractures post-fall. So let's say PCA, ketamine are ineffective and they're finding deep breathing and coughing very painful. They're on clopidogrel, which hasn't been stopped for a cardiac stent 1 month ago, so obviously very necessary clopidogrel. Do you place the paravertebral? And let's say have a chat with your partners about this scenario. And if you were to consider, this exam is pushing you towards a decision, you can imagine that, yes, I'd like to place an erector spinae block. Let's say you don't have an ultrasound, it's not working. Let's say the erector spinae block doesn't work. The examiner can make any judgment as to why something didn't work to push you towards making a judgment, making a decision. So have a think about this situation and decide what you would do.
In this case, I would, on consultation with experienced regional colleagues, place a paravertebral because of my concerns about respiratory failure, assuming that I've adequately consented the patient for increased risk due to that.
Yeah, sounds good. And the way I structure this is by understanding that really often there'll be no perfect anesthetic. So you've made a decision, so there's no perfect anesthetic. There's always 2 or more conflicting issues, and sometimes a really useful thing is to preempt the inevitable challenge. And you knew exactly what we're talking about. You'll consult with your regional colleagues to find out what they do with regards to bleeding. And so sometimes there might be a situation where you do want to talk around the issue to not just to buy you time, but it's complex, and you want to be able to express that complexity in an intelligent way. So you will probably identify in all the next scenarios that there are a few situations, there's 2 very particular problems that aren't ideal. And if by using the phrase appreciating the risk, you can just highlight that. So, appreciating the small increased risk of a, neuraxially located hematoma because the patient's on clopidogrel, it is such a massive advantage for this patient to have good pain relief with a paravertebral block. So I'd proceed with some advice and guidance, something like that. Let's go through these questions now. So 21-year-old male, penetrating eye injury for urgent ophthalmic surgery, what relaxant would you use?
So your consensus is that we would probably be, there's going to be a rapid sequence induction.
Yes.
The conflicting issues that we don't want to increase the intraocular pressure. So therefore avoidance of succinylsonium. So rocuronium would be at 1.2 milligrams per kilogram, our ideal choice for relaxant.
Sure. And what happens if you go in too early with your laryngoscope and cause the patient to move or buck and cough? What do you think of that?
That would be poor planning and not ideal, and would increase potential intraocular pressure. I would have given a dose of IV lidocaine and an appropriate dose profile with my rocuronium and alfentanil.
Mm-hmm. Okay, that sounds fine. Look, and all I'm doing here is just pointing out the questions that you might get asked. And some of these situations become less and less controversial as the years go on. But if someone wanted to use succinylsonium, you could easily just say, appreciating the small theoretical risk of a rising intraocular pressure, I'd use SUX. If you're asked to justify this, I'd use SUX because of its definitive endpoint and my familiarity. And so you could argue either way. So 50-year-old male, fractured tibia with severe prostate.